Okay, so the floor is open. We've got a fair amount of time and be happy to entertain questions. I've got one right off the bat.
Alan Gleepton, New York Obesity Research Center. I have a question for Dana Small. Dana, it was a wonderful talk. Thank you. I'm assuming that when you looked at metabolic rate, that there's no such thing as a conditioned metabolic rate. That is, you have to give them calories, that if you had given them a flavor that was paired with calories, you would not get an increased metabolic rate. Am I right about that?
I haven't done it, but I would agree with that.
Okay. And my second question is, in this study where you used the solid food, the salads, was there a corresponding brain imaging component to that?
Not yet.
Oh, okay. Very good. I just have a small critique of the salads, which is that unlike the drinks, which were equal in size, the salads were larger and had more calories. So the volume was not the same, right?
The volumes of the salads were all similar to each other.
Oh.
And the calories were similar to the drinks, but we couldn't get 0 calories, so we had 37.5.
Right. But I think in the slide you showed, it looked like they were bigger portions. That's what I recall.
Those actually weren't the salads. That was just an image downloaded from the internet.
Oh, okay. All right. Okay.
Anyways, thanks for the question.
Danielle?
Danielle Greenberg, PepsiCo. I actually have 2 questions. So the first one is involved with the idea that sugar and fat mixtures have not existed for a long time. And I'd like to suggest 2 different things. First is human breast milk, which has the highest sweet content of any mammalian milk and has an equivalent fat content to cow's milk, goat's milk, and certain other milks. So let me continue. And also, mixtures of fruits and nuts goes way back. And as a person of the Jewish faith, I know that milk and honey goes back at least 5,774 years. So that's one thing. But then also to Dana, I'd like to, another question about the salads, which is, wouldn't it have been a better comparison to use something like either raisins which you would have had to change the volume, or cookies or fig Newtons or something else that was also high carbohydrate? Because I'm sure that the calories and the macronutrients from your salads were not coming from sweet component. And so you're attributing it to a liquid-solid difference when it may in fact be a macronutrient difference. So if you wouldn't mind.
Okay, I'm going to start with the breast milk.
Okay.
I think that there are periods, critical periods, and I think that probably we certainly know the brain and the appetitive circuits are different, and I think that is about the only substance that has high sugar and fat. Now, you bring up raisins and milk and honey and raisins and nuts. When I think of this in terms of an evolutionary scale, I'm not talking thousands of years, but hundreds of thousands of years. And I think that even if you talk about nuts and raisins, there was a limited supply. It probably wasn't, so frequent.
Not raisins, but really any fruit. Berries, blueberries. I think that you will find if you look at history of cuisine that those kinds of mixtures go very far back.
Yeah, but not far back enough to influence the evolution of the system is my argument, I guess. So then the last question, the salads. The reason we use the salads, and you could try different things when we want to, is because we wanted to use the exact same stimulus as we did for the beverages. So we could make the maltodextrin dressing with so it was just basically the same flavor as the bilberry and all the things that we had been doing before, but it was just a little thicker and made into a salad dressing. I mean, we're definitely following up on that. And you're right, it could be macronutrient. I think it would be really interesting to try to understand what happens when you introduce other macronutrients into this response.
Yeah, no, my question is simply attributing it to a liquid-solid difference when your difference here is very definitely much more than that.
Yeah, I mean, I think that this was just the first question to see if this happens, then we follow it up. So I agree that it's not a definitive answer, but I still think that it's, I mean, we can differ, have a difference of opinion here, and evidence will hopefully come out if somebody gets a grant, hopefully me, but you know, so I think it's still an open question, but I do believe that you know, there's multiple ways to answer it, so we can definitely get an answer to the question, yeah.
Edmund?
Edmund Rolls, Oxford. I wonder if the panel thinks there might be any merit in terms of doing things backwards. What I'm thinking about here is we're starting off with a particular hypothesis. For example, that addiction is crucial to a lot of high BMI problems. What's happening in things like autism research and schizophrenia research is that we're taking very, very large databases that, say, have 500 patients and 500 controls. And then we're doing brain imaging, or the brain imaging is being collected on those. And then we look for differences, which in this case might be, say, correlations with BMI. And we also do correlations then of the bits of the brain that we find with the different questions. So we wouldn't just take the whole of the Yale questionnaire. We could take individual questions from it and some other questions as well, and see which ones correlated with the activations in bits of the brain. And then one also tries to put into these big database type studies biomarkers as well, for example, genome data, to see if you can get a biomarker that then correlates either with the activation in some bit of the brain or possibly with something that's coming up in a question. So that would have big implications for funding. It wouldn't have to be one big study, but it could be lots of labs, each putting in sort of data from perhaps 20 to 50 subjects, but they would have to be agreed as the same set of questions and biomarkers that were being measured. So I wonder if the panel have any sort of reactions to that sort of idea, that that might be another way to go about this, and to see if there really is perhaps then a subclass of people who should be described as being like addictive people.
So I think that, is this on? Can you hear me okay? Here we go. So I think a study like that would be really wonderful if we could have larger sample sizes across multiple different sites. And from our perspective, one of the things that would be important there is if you do want to test the hypothesis of addiction and you want to see, does this correlate with something that you think is a proxy for addictive behaviors, you know, what would that be? And so, as I said in my presentation, you know, our response would be, don't just use high BMI, but look at behavioral indicators that are classically associated with addiction. So I think if you can have similar measures and agreed upon definitions across a large scale of sites to start to look at this overlap between behavior and brain, that would be wonderful.
I just second that idea. I think it's a great idea. But the one thing that we ought to be mindful about in those sort of studies is that they're not entirely hypothesis-free. We've got a phenotype that we're interested in, that we're looking at. We're collecting imaging data on specific measures, which are, of course, based on existing hypotheses that underlie those measures, as opposed to just looking at brain structure, which we can do in a relatively hypothesis-free sense. And I think while the idea is great, collecting that data does require several levels of specification before we get to it.
Hi, Caroline Smith-DeWall. Thanks for everyone's presentations. They've been really informative. When we talk about drug addiction, though, we don't really talk about drug addiction. It's cocaine addiction, heroin addiction. You can have caffeine addiction, alcohol. These are chemicals. I'm wondering if the issue of food addiction isn't really the question of, are we adding an ingredient or a chemical that's overriding the hormones that signal satiety? I mean, just kind of tying together this morning's session with this afternoon's session. Are we really looking at a chemical reaction that's having the impact? And does anybody answer that question or know the answer? Thank you. Oh, and my second question is there anything we can learn from cultural differences? For example, Asian cuisine often and I don't want to overgeneralize here, but may have less emphasis on sweet and more of an emphasis on umami. So those are my two questions. Thank you.
So I think the question you have is a good one, as when we think of drugs, we say this is nicotine and this is ethanol, and we have a good sense that the higher the percentage of ethanol in a drink, the more likely people are to develop an addictive response to that. And we definitely aren't at any sort of spot where we know that with food yet. I think that the evidence in animal models, Nicole Avina will be coming to speak with you tomorrow, and she's been one of the kind of major researchers in that field of animal models of addictive like eating behavior, with sugar in particular sticking out as a possibility. And in humans, it's really kind of just beginning. Food is so complicated in many ways. I look at a Pop-Tart and it has 60 ingredients, many of which I can't pronounce. And it's hard to tease that apart. But if I had to put my money on something, I would think that it's refined carbohydrates, fat, and salts in combination and in extraordinarily high levels is likely the thing that our brain shows enough of a response to that we start to show behaviors that are consistent with an addictive-like process. But we'll need really well-done science and data before we can feel confident in that. Culturally, I think within the addiction realm, we find that one of the things that can be protective against an addictive substance being a widespread problem is that it has kind of socially constrained periods in which you use it. So wine is part of a church service, or you only use a certain thing when you're in a certain social setting. And as those cultural definitions of when it is or isn't appropriate to use the addictive substance start to erode, you do see increases in addictive-like behaviors. So I think this might be relevant to food, where our idea about how we eat and when we should eat, and snacking and eating at our car and eating at the computer seems to be kind of different culturally than the idea of sitting down with meals that was perhaps more prominent 40, 50 years ago.
I'd follow that. I think the substance thing is critical, and the DSM-4 criteria don't actually, if you look at the fundamental behavioral criteria, the assumption is that you are using a substance, and in the context of using that substance, all the above apply. And I think that the criteria for gambling have obviously been revised in the DSM-5, but when they were under pathological gambling in the DSM-4, now that was defined as a behavioral syndrome purely with a behavior. And I think with food, we're very clear, we're in the substance camp, that there is something that's being consumed that is important. And I think at present we're at a stage where we don't quite have an idea of what that quite is, and we're accumulating evidence for a behavior based on a potential agent that we don't quite know. And I think it's important to actually clarify what that agent is to use any of this meaningfully, because as the person who asked the question, the substance is critical. And though we have all these substances under one umbrella, the pictures of addiction are very, very different across them in more ways than just the behavior, actually. And I think there's something more to be considered in terms of looking at addiction per se, and I'm talking just about drug addiction, as going beyond that behavioral syndrome. And we do have accumulating evidence that there are several other elements to that picture that extend beyond that behavioral syndrome. But I think we're able to do that because we've got a substance as a sort of starting point. I don't mean this as a criticism of, we have no substance, therefore there's no addiction. But I think the fact that there is no substance is very much of a problem.
Mike?
Yeah, so Mike Kelley from Wrigley, and I think there's a question or just fishing for thoughts from all of you. At least three of you used some of the data from the published studies, and we looked at activation of reward centers in response to or in association with food addiction scores, and then there was some other data. And when I look at that data, I see the regression line, and I think I can see the pattern, and I think a lot of the scientists here, we learned that. But then I look at those lines, and if I look below them, I see that maybe half the subjects aren't showing such a high response, but across the x-axis, you've got a fair variation. And so I may be torturing the data to give me what I want, like David Krzyzewski used to say, but I just wanted to get thoughts on that, because you mentioned in the public eye, addiction is thought of like a light switch, it's on or it's off. But your data shows a continuum, And so I wondered if you could address that a little bit more. And I also wondered about those pleasurable responses, the other types that are not in response to food, why we're not chasing after some of those, which may be just as strong. Are they not in the same areas, not activating the same reward centers? Would love to have thought on that. And then lastly, Dana, you're living in the geography of combinations of fat and sugar, and those have been elevated to an art form. So perhaps you'd comment on that. That's been around at least for 60, 100 years or so, not human history. So what are your thoughts on why overweight and obesity is ramping up recently when those sorts of things have been available and not just to the rich? Okay, thanks.
Where do we start? Yeah, well, I think that, well, I mean, I haven't done the sugar-fat combination. I do think that, going back to the previous question, the substance, the food, is going to be critical, and that there's certainly modern foods that have been created which challenge our physiology in ways that it did not evolve for. And I think when I say evolve for, I'm talking hundreds of thousands, a million years, not in terms of the last 100 years. In terms of whether or not, when we started making butter and applied that to sugar things, and was that really the start of when people started having increasing weight? Well, I mean, I don't know that there's any good evidence about that. I don't know how well people have looked at it. I don't know how possible it is to look at it. But I think that it's also just one aspect, because you have to consider also, and this is something we haven't talked about, the entire environment. So, for example, if you have these high-processed foods and you're stressed out and you're not sleeping and you're not as insulin sensitive because you're not doing as much physical activity, I mean, there's many things that sort of contribute together, and perhaps, we hit a critical mass of these things and you get higher rates. But I certainly think that evolutionarily we have, the certain foods, the high-fat, high-sugar foods, I do believe are challenging our physiology in a way that it did not evolve for. And that could have unanticipated effects on metabolism and on guiding behaviors.
So I'm not sure where the addictions on like a light, I don't think I said that. I'm not sure where it came from, but I actually think the evidence doesn't suggest that, that there's this very discrete line, you're an addict or you're not. The DSM-5 in many ways has changed to say that this is a more continuous process, that people can show a range of addictive-like responses going from none to subclinical to clinically severe. And pretty much for any given addictive substance, we only see that about 10 to 15% of people, of even frequent users, of users of alcohol, actually show a full-blown level of clinical addiction. Yet many, many people show subclinical responses, to the point where this subclinical addictive response for a cheap, legal, easily accessible addictive substance ramps up its public health costs. So it's the third leading cause of preventable death, even though a small section of people are actually fully addicted to alcohol. So one of the concerns that we have with food is that if these certain ultra-processed foods are capable of triggering an addictive response, the vast majority of people will not be fully addicted. In our scale so far, it's been this 10 to 15% range, like other sorts of addictive disorders. But there's something different about that food. And on a public health scale, certain people may show enough of an addictive response, enough of a craving, enough of a loss of control, that they consistently eat 100 or 200 more calories than they homeostatically need. That is sufficient on a daily basis to take one from a normal weight category up to an overweight or obese category. So if these foods, which I think is kind of our resounding theme, we need to figure out what foods and what food characteristics may be addictive. It's not just going to affect people who are clinically fully addicted, but the full subclinical range.
I'll just add that this discussion brings up another of the important differences between DSM-4 and DSM-5, because in the time since the publication of DSM-4, there's been a lot more research, and we came up with the evidence that there really is a gradual process. So in DSM-4, there's a substance abuse category, and then there's what in that is called, in that version is called dependence, more severe. But we find that it's really on a continuum, and that's why we just use counts of symptoms. There's no such thing as a mild addiction based on any kind of data that we have. It tends to be a progressive disorder, and there are various limitations on the progression, such as drug availability, such as genetics, such as environmental factors. And as a matter of fact, when I teach my students about this, I tell them that they have to think in terms of multiple simultaneous variables, so that there's so many changes that can occur, but it's a whole process because there's so many classes of variables that the outcome of, addiction or not addiction is the outcome of quite a lot of process, not the least of which is genetics. And you have to understand that of all the mental disorders that we know of, there's stronger evidence for the genetic basis of addiction than any other. So it's a really important factor that we have to be thinking of in all our discussions.
I want to just raise one point about the nature of the food, because I think this is not an uncommon debate about, there have been foods like this, there haven't been foods like this. I think there are clearly differences in foods we have today compared to foods we had 50 years, 100 years, whatever. And while all those points are valid about what their potential public health implications may be and how they may affect the population as a whole, I don't think that in any sense is specific to the idea of them being addictive. I think that if you have highly palatable or high-fat, high-sugar foods, they are likely to have public health consequences because they may not, they may stress our physiology beyond limits that it's evolved to, whatever, and they may have health consequences, but none of that directly needs to invoke an addictive mechanism for why that's happening. And I think that's just something worth bearing in mind, that these foods, and there are probably foods out there that a lot of us will think are bad, and they can be bad even if they're not addictive.
Chandler Weiland, Dr. O'Brien, thank you so much for your contribution. I remember when the DSM was only 3. I used to work in Akron, Ohio at St. Thomas Hospital at Ignatia Hall. I just wanted to acknowledge you for your contribution. Thank you so much. My question is towards Dr. Gerhardt in response to her call for research funding. Today's children eat unsupervised more than my generation. And I feel that there's a knowledge deficit, possibly related to insufficient parenting skills, in regards to etiquette, proper using of tools like a knife or chopsticks. And because food, right now, it seems like with my children, their friends are having kids. And they eat with their fingers all the time. There's nothing wrong with that, but there might be a self-esteem issue possibly contributing to these children's behaviors towards their eating behaviors, perhaps, just an idea to perhaps use that as a criteria when you're setting up another experiment involving children. Try to have a group with a solid unit where family meals are a common occurrence, a daily thing, and see if any of those children have any of those deficits. So just...
So you're touching on an important literature, and it's one that isn't my main focus, but Dr. Julie Lumang and Allison Miller do a lot of work looking at parenting and child-parent interactions and how that's related to different eating-related outcomes. And so, some of the work that they're finding is that, certain warm and kind of, we call it authoritarian, I believe, the healthy one with an A. Certain sorts of parenting techniques do help children eat healthfully. But what they're also finding is that it's kind of not as simple as just the parent needs to show the kid the way. There's a lot of struggle where we see obesity really being problematic in low socioeconomic status areas. And so there's things like access to food, or the ability to get good childcare, or the ability to be at home if you're working 2 or 3 jobs to make ends meet, and the kind of food you can bring into the home. And advertising to kids, where there's characteristics about the child where they may be more or less sensitive to food advertising and throw more tantrums about getting certain foods or not. So I think parents can certainly be a really important tool, but I think we have to support parents to help them get the most health for their child, and I don't feel like our environment does that to the best of its ability right now.
But the American culture surrounding a family meal is just not what it was.
It's definitely shifting.
It used to build a child's self-esteem, to share what they did that day, to show growth, even in the use of tools. I remember when my daughters could use chopsticks without a rubber band.
Yeah.
It's a big deal. But it was only through practice, and they only got the practice when they were supervised. And it's
Yeah.
the unsupervised eating that I think leads to emotional eating, which is in of itself the problem, not the food.
Yeah, it's an interesting hypothesis to look into more. Thank you.
Tim?
Yeah, on Moran, Johns Hopkins. One of the things that Dr. Gerhardt brought out correctly is that substances that are abused, if they are more rapidly absorbed, they have a higher abuse potential. And where there was a little bit of a disconnect for me was how you were relating that to highly processed foods. Is it a taste phenomena that you're talking about here, that they are addicted to what the taste is? Or is there some secondary consequence of consuming these foods from a metabolic standpoint that's contributing to what the food addiction is?
So we're trying to look at this right now in my lab, and we have both hypotheses. Is it taste, is it metabolic? So our hypothesis, the one that we are most leading with based on what we see in the drug addiction literature, is we think it's probably metabolic, is our guess. Although, not in an experimental paradigm, yeah, absolutely. Our thought is it's really challenging to disentangle a really intense sweet flavor from the really intense sweet absorption of a high glycemic load food into the system.
Right, exactly.
So it's very challenging to say. I think it probably isn't an either or at least I wouldn't have strong evidence to say that at this point. But I think some of the literature suggesting sham feeding and seeing differential effects when there isn't a metabolic process that's going on, to me makes me think that the metabolics are really important. But we'll have to test that out. We're not sure.
So highly refined carbohydrates and complex carbohydrates are going to empty from the stomach at exactly the same rates. They're going to have the same effect on releasing insulin. And here's where it becomes difficult for me. You're getting a phenomena with one kind of a food, and you're not getting it with the other that are having very similar metabolic consequences.
And I think we'll have to test that out to see whether we do see differences. I'm always a little suspicious now when there's foods that are, you kind of have the refined carbohydrate and you have the complex carbohydrate version. And I don't think we've seen good evidence that if there's a breakfast cereal and it has whole grains versus the refined grains, that people are less likely to binge on it. So I think it's an open question about what differentiates these different foods. And I guess I think on this broader level of kind of this, the difference between something like a banana that has a decent level of sugar in it, but has fiber and water and different acids where we, can't even eat it nearly as quickly as tossing a handful of jelly beans in our mouth with the same sugar content. But also it's likely absorbed differently. And so where we have to ask these questions is, here's a whole bank of foods. Here's their characteristics. What differentiates the foods that people eat in this kind of addictive-like phenotype versus those that don't? And then we can say, man, the things that really seem consistent are things like the level of dose of fat or the speed of absorption of the increase in insulin. But we don't know that yet. We're going in trying to take the theoretical bent of what we know from drugs of abuse and to see whether they apply. And I think if they don't apply, that's good evidence that this theory isn't valid.
I would just follow up with one quick question. So sugar and fat seem to be special in the discussion so far, but they're quite disparate in their rate of absorption. If, in fact, that is an issue, that processing food alters rate of absorption, why would fat be in the same category?
I want to respond to this. Sorry. I mean, I think this is really the critical issue. And, Ashley's talking about the different types of foods and one way to look at the question. But the other side, of course, is that we don't know what the critical signals are. Is it, sensing in the portal vein? Is it, certainly it's going to be different depending on the macronutrient. So, for example, fat is going to have a whole different pathway to modulating reward circuits than does glucose. And I think that this is a really important thing to first work out exactly what the timing, what exactly is going on at the mechanistic level in the gut that is controlling dopamine circuits as one measure, for example. And then how do the different foods that we have in our environment interact with those particular circuits? And at the level of the central nervous system, how do those separate signals, if you have, for example, sugar and fat together, interact in the brain to potentially do something that, again, was not the original evolutionary intention of the system?
I want to just raise a slightly skeptical challenge to the idea of refinement as a measure of potency. I think that's quite an appealing narrative that you start from the coca leaf and you get to crack cocaine. And what you've done, presumably going from one to the other, is increase the potency of the substance. I'm not sure necessarily the parallel applies if you start from complex carbohydrates to highly refined sugar. But I think even within the addiction field, that's not quite as straightforward. It's probably important there to consider the idea of tolerance, that actually what you get when you go from low quality cannabis or cocaine to crack is actually you get higher potency when you have higher need, and that's probably quite a complex relationship. And I think even when you look within clinical populations, people choose different levels of potency that suit them, and there are some people who choose not to go for high potency drugs. That's not an inevitable progression that you start from low potency to high potency. There are people who stop at a level of potency that works for them because higher levels start to get aversive. So I think it's a bit more complex than the idea that we just go from high to low and that automatically maps onto addictive potential.
This is just another of the very significant difficulties in extrapolating from food to drugs, because the route of administration is so important. We took something like coca leaf, which for 5,000 years was used without much trouble, and by changing the route of administration caused it to become a terrible drug. And really pernicious because it's cheap and easy to get into the brain very quickly. With food, there are small differences, I'm sure, from in absorption, but still you're talking about an oral mechanism, and it's very different from going, either intravenous or intra-lung. So these are huge differences in addiction potential.
There's some recent work, again, from Ivan Diarujo's lab speaking to this point with food. So he has done intragastric glucose administration, so rats are lever pressing for IG glucose versus oral. And when the administration is IG and there's no oral stimulus coming along, then it just doesn't extinguish. The behaviors look much more like they do when they're addictive. When it's drugs rather than food. So, this goes back to the question of there's clearly addictive drugs are acting on the circuits that evolve for feeding, but they're doing so differently. And, we have to take this into account when considering eating in our modern food environment, but also, for example, the match between the oral sensation and the physiological impact is now different. And so could that potentially get you in a situation where you don't have the proper oral signal to create whatever that environment is that somehow, with the cocoa leaf, with whatever, seems to suppress the addictive-like behavior?
So I think that also it's an important question for us to ask is when we ignore these differences that you just mentioned and try to squeeze them together, and, are we gaining anything? Or would it be better to just set up a separate category, because because so many phenomena in biology and especially in medicine that have similarities and differences, and you can be a lumper or a splitter.
Hey, so I have kind of two thoughts. One would be that you're right, it's oral consumption, which is different than our most intensive routes of administration. But I think when we look at alcohol, we all agree that alcohol is an addictive substance and that there's variability within orally consumed alcohol that makes it more or less addictive. And a lot of that has to do with the potency of that active ingredient, the level that's in there. So there's a very big difference between low alcohol beer and hard liquor and whether or not someone's likely to experience some sort of addictive-like responses to it. So I guess I think some people suggest alcohol as an addictive-like food. You get calories, you get these sorts of things that your body needs, and things like ghrelin and orexin are starting to come up as particularly important in the development of alcohol addiction as well as to eating behaviors. So I think that it being an oral route of administration doesn't necessarily mean that addiction can't take place. I think we have good evidence that it can. And then the other concern I have is I think that before we have the data saying that we should just put this in a different category comes with risks as well. And I think it comes from the tobacco world that in doing this work, I go back and read many of the papers from the 80s and 90s that very vehemently said that there was no way that tobacco could be addictive because look how different it is. It's legal. You don't even get intoxicated. It's something that is totally socially acceptable. And so if you compare that to something like heroin addiction, it seems so different. And so we should just apply the term habit forming to cigarettes and give it its own category. But I think there are things that you miss there. It's both an understanding of mechanism, but it's also understanding the power of that substance and the ways that we've approached that in a policy or a treatment way that has been effective. So I don't think we're anywhere near that point yet with food, but I think we need to remember that there's a vast amount of variability between something like cigarettes and something like intravenous heroin use.
Bob, I think you've actually been standing the longest.
From my somewhat ignorant background here with regard to addiction, I understand that addictions are generally thought to be produced by the substances to which an individual becomes addicted. In other words, the substance you're taking produces a change in the nervous system that results in this feed-forward problem that you see. I'm wondering whether it's at all a concern whether the addictive, and I don't doubt that sugars and fats can produce those sorts of behaviors, but I'm wondering whether you're at all concerned whether the addictive behaviors that you're talking about in people necessarily arise from the use of the substances. Or, in other words, another way of saying that is, does addictive behavior cause increased BMI, or do people with BMI have an underlying problem that result in their expressing their need as an addictive behavior? And I'd like to I'd like to see more consideration of that, because I think there's, in all likelihood, prodromal or predisposing factors like that, as there are for other addictive substances. But I think we're perhaps in danger, if there is such a thing as food addiction, of not recognizing some of the underlying causes.
Well, I think actually with drug addictions, there is a lot of it that has to do with the drug, but I think increasingly our model is that there is a lot of it that's predisposing. We've got work from one of my colleagues in Cambridge, Karen Ash, who's actually shown that if you look at the siblings of drug users, and this is a lot of work from cocaine dependence, that actually they show very similar baseline vulnerabilities to their drug-addicted siblings in terms of changes in brain structure, personality, variables such as impulsivity and inhibitory control. And I think all these things clearly predate the onset of, I think increasingly think that they actually predate the development of addiction. And then you add the substance in, and then that enhances the problem. And you get a complex of substance plus pre-existing vulnerabilities. And I think you're absolutely right. It's the same thing that we've got to take into account if we are thinking about food addiction, because it has to be that combination of an individual and a substance. Because just like with substances of abuse, lots of people take them. A relatively small percentage actually go on to develop a clinical addiction. What exactly those vulnerability features are for a potential food addiction might actually be fairly similar, at least in terms of some basic variables such as inhibitory control or executive function. But I don't think we've actually got the data to speak to that yet.
Yes?
Oh, okay. I'm sorry, I have a code too, so forgive me. But I like the comment that you made about patients have problems and rats you can buy by a dozen, you can get them clean. I do believe that when it comes to food addiction, that it's a very difficult thing to list under the new DSM-5, because again, that potency component of it, once you identify that substance in food addiction, you would have to then figure out how much of that substance, the potency of it, that would cause one to be addicted. And then you have the behavior component to it, and that is, how much does food addiction really affect or impacts one's life? Will food addiction cause one to lose a job? Will it impact their education? Will it impact their family environment? I mean, there's a lot of questions centered around when you start thinking about food addiction as food as an addiction. And my other thing is about behaviors. You know, how much do your behavior influence your eating? Because when one could say that, like I could be perfectly not hungry and I can look at going to a candy store and all of a sudden, because of what I'm looking at, or if I'm in a depressed mode, I might want to eat to alleviate that. So how much of our behaviors activate our taste cells? So, that whole relationship as well. So that's pretty much all I really want to say. But Robert pretty much hit on what I wanted to say when he just asked the question too, so it's kind of in line with that as well.
Any further response? Or? No? Right, go ahead.
Kathy Greaves, the Kellogg Company. I want you all to be clairvoyant, look into the future, maybe 20 years, but first grounded in the fact that sugar and fat are absolutely required by the human body, right? Fuel's absolutely required by the human body. And so it's no surprise that it lights up the reward system when we eat sugar and fat. Although, I question some of the methodology, but it shouldn't be surprising to us that the reward system lights up. And it seems like there's already some, in the literature today, some clear opinions around the fact that sugar and fat may be addictive substances. It's in the literature, that suggestion. So if we look 20 years down the road and we decide that sugar and fat are addictive substances, what does that look like in terms of where we go with our food system?
I've never done this before, but I would direct you to a YouTube video on that matter. Sorry, I've never done it because I don't like plugging, but I think you could take that several ways in terms of how it might materialize. And I think the critical thing is actually what would you do based on that knowledge? And based on that step, there are several ways that it could potentially go.
I just want to add that I think with tobacco, the issue was not that it was addictive that eventually got the regulations against it, but the fact that it was carcinogenic, which is what they were trying to hide. And I think that in terms of fat and sugar combinations, well, certainly we're getting obese, and that's can be related to cancer. There's just no question that.
Well, if I could just stop you for a second, we don't need tobacco, right? We don't need tobacco, right? But we do need fat and sugar.
But we don't need Fruit Loops, and we don't need Pop-Tarts. What we need, I mean, the point is.
So I'm asking you, look 20 years down the road.
Yeah. I mean, I think that the reward circuits evolved to stimulate eating. And I think that not just for homeostatic reasons, but also for hedonic reasons, we need that system, and we have evolved the ability to store fat because there's times of famine, so it makes sense to do that. The problem is some of the foods in the environment that we have now, both their presence, and yes, we had sugar and fat 100 years ago, but we didn't have sugar and fat in every corner and have it 3 meals a day. I mean, we're overtaxing a system, and in 20, 30 years, what I would hope that we could do is figure out exactly what are those mechanisms that are being overtaxed, and how can we change our food to make it similarly palatable. And of course, we need energy to survive. We don't make it, we have to consume it, but we don't necessarily have to consume the kinds of energy that we're consuming at this point. That's clearly a problem. Whether or not it's addiction, I don't think really has a major impact on how we act on it. And but I think that there are certainly, it is our job to figure out exactly how to change the food environment so that we can, and I think that we should and we will, and work with industry, work with food scientists to figure out how to remodel. I don't know if that gets at your question or not, but.
Yep.
Hi, I'm Joe Herskovic. I'm a workshop committee member, and this is for Drs. Gerhardt and O'Brien. It's kind of related to the other question, but a little different. And given that the issue of food addiction is unsettled, as clinicians, how do you treat patients now, and what would you do differently if we did add food addiction as a category?
So I treat people who have binge eating disorder now. And what I do right now is cognitive behavioral treatment for binge eating disorder. And we actually have a paper out there that if you look at many of the mechanisms that we do in cognitive behavioral treatment for binge eating disorder and addictive substances, many of them are the same. You focus on what are your cues and what triggers craving for you and how do we help you regulate your emotion. Where I could see it going in the future is if we start to understand that certain foods might trigger an addictive response in these individuals. I think the idea is how do we help you moderate or in extreme cases even potentially abstain from eating a certain sort of food that's particularly problematic for you. Do I think that's the answer for everyone? No, I think it actually would be a very rare case that we would try and help people abstain from chocolate or French fries. That being said, from an addiction perspective, I think one of our empirically supported treatments that's informative is harm reduction. And so we don't say, you can never have alcohol again, but we say, how do we help you drink alcohol in a way that's safe for you? And often we identify environments or emotional states or different ways that we can kind of build in to protect that person. And where I think about that with eating is I think about things like being in extreme fasted states where you're extraordinarily hungry and then exposing yourself to large amounts of these foods is probably very risky for certain individuals. And I think there's things like that that we can think about and help work with our clients to identify ways for them to consume in a way that meets their goals.
But all those things you're doing now, right?
No, because the one thing right now that you're doing is the traditional way of thinking about this is that there's no good food and there's no bad food. And there's just the way that you think about the food.
But the cue exposure, the stimulated triggers that you're talking about, all this is parallel to what's been learned about addictions over the years, but that wouldn't change if you get an official declaration from the World Health Organization that food is an addiction.
So
I don't think it's going to change.
Yeah, no, so two things that I think would change is that right now one of the ideas is that the main mechanism is the restriction is the problem. And I think if you bring someone in who's in alcohol treatment, they have tried to do 17 things to try and restrict and moderate their alcohol consumption and have repeatedly failed. And we wouldn't say that restriction of alcohol consumption is the problem. One of the main mechanisms of treatment that you do in eating disorders is try and get rid of that restriction behavior. And so I think that it would change the importance of that for some individuals, but also one of the other aspects that you do is you try and add that food into the diet more. So we'd say, you have issues around chocolate, let's have you try and eat chocolate more so you're not as restrictive around it. And I think for some individuals, that may not be effective for them.
But I think the official declaration isn't going to change because these are things that you're doing anyway. I mean, I was taught how to do cognitive behavioral therapy in the 1960s as a resident under Tim Beck, who pretty much thought it up. And essentially what he said was, just use common sense. Just use your grandmother's philosophy, and it pretty much worked. I mean, that's what I think that the big improvement in psychotherapy over the years, in my opinion, is besides the discovery of medications that really make a difference, but that in terms of talk therapy, we're pretty much research-oriented, evidence-based, and using common sense rather than searching for an edible triangle in every case and things like that. That just has not proved to be fruitful.
Yes, go ahead.
Hi, Patricia Williamson from Tate & Lyle. So I've had a myriad of thoughts going through my mind as I've been listening to this. And there was another session at another meeting not too many weeks ago where and this is kind of a multi-part thing, but is it true, or would you agree with the idea that only about 1/3 of people develop any kind of addiction, even to addictive substances? So some people can try cocaine and walk away, or have a lot of alcohol and maybe never have it again. Some people go up smoking for Lent. I had a grandmother that used to do that. And then the other thing, so for her it was more of a habit than an addiction, I guess you could say. And the other thing I'm wondering about is, I don't think about us as being addicted to Fruit Loops. Now, those little marshmallows and the Lucky Charms might be a little questionable. But as far as binge eating, someone mentioned earlier this emotional eating. And I wanted to kind of broaden this out beyond the food, but maybe our overall social environment. And are we entering a space where, like in the last 30, 40 years, we're suddenly seeing a very dramatic climb in obesity? Obviously, a lot more TV time, screen time, that sort of thing. But we're also seeing, and I'm a hard-working single mom, but we're also seeing a rise of women in the workforce and increasing stress levels, pressures at the job, pressures economically, and the bar charts that were shown earlier, where the different people had different loads of stressors that went in hand with their addictive behaviors. Could it be a cortisol-related situation, has anyone explored the relationship between socioeconomic stress? Got work hard at my job, eat hard at night, Doritos make me calmer. I don't know. But, is that relating to binge eating? Are these people succumbing to bill pressures and job pressures? And that's putting them in an emotional state of binge eating?
Yes. There's actually quite a lot of work on this. There's, at Yale, Rajita Sinha has one of these roadmap projects. It's just, in fact, looking at the effects of stress on compulsive behaviors, including feeding. And they've really shown, for example, that morning cortisol levels upon acute stress. So, and I was involved in this, if people who had high morning cortisol levels, which is an indicator of lots of chronic stress, that if you stress them out while they're eating a milkshake, their Q reactivity is way higher. So, I think that this is, it's a confluence of a bunch of things, is what you're saying, that really makes matters a lot worse. It's not just the nature of the food product. It's, as Laurette Dubé is trying to work out, it's a whole bunch of things. And, really to combat the obesity epidemic, this is getting away from addiction, what we need to do is figure out how these things interact, and that's going to take big science.
But does that drive?
Yeah.
The processed food isn't, it may be the thing that people are turning to, or what you might think, but it maybe that's just a symptom of the deeper cause. It's not necessarily that they're driven to that food because it's there. Maybe if they had other pressures out of their lives, they wouldn't do that at all. The food just happens to be there, and it's not really a result of the food's problem. It's not because the sugar and fat suddenly are together. Because, I would think the French have been eating pastries more than the last few hundred years. I think, that's probably been going on for several centuries. Because they're just really good, and you have to take a lot of practice to get there. But, so sugar and fat together, that's been going on for a lot longer than we've been dealing with people being addictive or to food. And so I think maybe sometimes we need to broaden the scope and not blame one item. Maybe that's just where I'm
So I've just got to evoke chair prerogative or something. You were all brought together because you are experts in methodology. And so I want to finish with some questions that get at that, because this field is now, I think, suffering from a lot of conclusions drawn on intuition and what seems like common sense, but not science-based. So if we get down to methodology, help us read the literature, help us interpret the science. So I've got a couple of questions for the two camps. So in terms of the imaging world, when new technologies come out, there's a honeymoon period, you're allowed to use shotgun approaches and find things. The field has improved. There's now often hypotheses in imaging studies. But has it reached a point where you are willing to say, register in clinicaltrials.gov, this is my endpoint. This is the brain region that I think should change if I give this manipulation. And if you don't see it in that region, you don't publish your results because the rest was serendipity. It was not your hypothesis. That's the way the nutrition literature is going now. You have to be honest about your outcome measures and at the beginning of your science. Is imaging at the point where people should be doing that and readers should be expecting that?
Yeah, so we're trying to do that right now. Whether or not we'll be successful, I don't know. But, there's a lot of evidence, for example, that the response in the dorsal striatum to a milkshake is lower the higher your BMI. This is some work that I was doing with Eric a long time ago. And, this relationship I've now seen in 6 or 7 studies, apart from what we do in our lab, and I see it in every study that we do. The relationship between response to milkshake in the dorsal striatum and BMI is really strong. What was interesting is that when you gain weight, that response decreases. But if you're at risk for obesity, you don't have a decreased response. So it suggests that this is an adaptation. And we've been working with some compounds that will not be mentioned that we're hoping to reverse that effect. So I think that, and certainly from Paul Fletcher's lab, this is exactly what they're doing with the maybe not everybody in the lab, but I think that that's exactly where we're working towards. And if you have a well-constrained paradigm, then I think that you can get very replicable results, and it can be useful in clinical trials. That I do believe that. Yeah.
I think it could be, but we're not at that stage yet. I think the closest we are at the moment is we can use imaging reasonably well within a controlled retest paradigm. That you do a baseline, you then apply your intervention and then look at a change from baseline. I think the ideal point we want to be at is where we're confident enough to say, we'll do an intervention and we can look at this measure as our endpoint without looking at it as a change from baseline. And I don't think we're anywhere near there yet.
I agree.
A second question, methodological. So our behavioral folks have stressed the importance of gradation of response. Severity is an index of a diagnosis or whatever. With imaging, the data that is often presented is this area is lit up, that isn't. It wasn't before, it is now. It's a yes, no, on, off. Is there an expectation that there will be gradations of response that imaging can pick up that will give the greater specificity that seems to be sought in the behavioral measures?
Well, I think definitely, and even those studies that Dana was referring to, where we're looking at the dorsal striatal response, a lot of those are essentially regression analyses. We're looking at a gradation of response to BMI. But I take your point. I think in a lot of places we do tend to present dichotomous outcomes. In fairness, a lot of those do start with dichotomous questions. Is there an area that lights up, yes or no? But we do certainly need to get to that level where we're by and large trying to apply that in a way where we can use it as a continuous graded measure, which is much easier to probably integrate with other measures that have to go into complex models.
Okay, so then I'm not just picking on the imaging people because we are running out of time. So this idea of gradation, can your model, your questionnaire, differentiate the transition from use to abuse to addiction? Are there different scores that you can say, oh, you're this far along the process?
So one way of looking at the measure is looking at the symptom severity count of how many symptoms, just like they're doing in the DSM-5 now, how many symptoms are you meeting? Where we aren't at yet is saying, we do see higher scores are related to more severity across a number of ranges, BMI, elevated body mass index, increased risk for diabetes, et cetera. But I don't know if we have like the specific, at 2 you go from use to abuse, and at 5 you go from abuse to dependence. I also don't necessarily know that we have that confidently and scientifically with the other addictions. We kind of draw a line in the sand and say, this seems to be more mild, this seems to be more moderate, and this seems to be more severe. So we definitely have a dichotomous way of looking at it that reflects the traditional way of scoring the DSM, which is the same way you score any other addiction, 3 or more symptoms plus clinically significant impairment or distress. Or you can look at it in a more continuous way as well, which would give you a better sense of severity gradation.
One more from me. So what is the test-retest correlation for your scale over extended periods of time?
That we have data coming out on that has been collected, and I don't know what the numbers are. A student of mine is doing that, so I can't speak to that at the moment. We have more validity tests than reliability at this point.
All right, we are about out of time. Is there one final question? Anything from the viewing audience? No? Okay. Thanks very much.
So I'd like to just thank all the speakers and the moderators today. I think that was great. We went from biology to psychology and everything in between. And we already got a really good start on our addiction discussion, which we're going to continue tomorrow with a point-counterpoint. So I hope everybody can make it. I just want to leave us with one thing. I think Dr. Dubé talked a little bit about distractions and how distractions can impact hunger. And I just want to quote from the Brazilian dietary guidelines, which say, number 5, eat in company whenever possible. So please go out and eat with a friend tonight. Don't sit at home and work and eat. So have a good evening and hope to see you tomorrow.